is hosted by the Great Plains Quality Innovation Network, the Center for Medicare and Medicaid Services Quality Innovation Network, quality improvement organization for North Dakota and South Dakota. My name is Tammy Wagner, and I am a quality improvement advisor for Great Plains Quinn, and I want to thank you for joining us today. Our team members for the Adverse Drug Event Series, along with myself, are Carrie Sorensen, QI advisor and pharmacist, and our communication staff, Kelsey Olson. We will have an office hours format for questions and peer sharing between any organizations, but you can also add any questions to the chat and they will be addressed at the end. We have added a resource document you can access. This resource document includes the resources that were shared during the original Focus for Health from January 2023. And when we have other links to share, we will add those into chat. Preventing adverse drug events is a major priority for health systems. This 4-week series is somewhat of a repeat. It's a hybrid of sorts from our January adverse drug event series. We don't ever think it hurts to hear more about adverse drug events more than one time. You might be in a different place than you were, maybe some different staff. This 4-week series will include discussion and education, and today will be on adverse drug events and safety. Week 2 is prescribing and transcribing medications. Week 3 is dispensing and administration, and week 4 is care coordination and how that affects adverse drug events. So most adverse drug events are caused by commonly used medications that have risk, but they do offer significant benefits if used properly. In patients 65 years of age and older, anticoagulants or blood thinners such as warfarin or anti-diabetic agents such as insulin and opioid analgesics are the top 3 high-risk medication classes that account for approximately 60% of emergency department visits for adverse drug events. Fourth in prevalence are antibiotics. And antibiotics, lost my place here, are responsible for approximately 16% of emergency department visits due to adverse drug events. The 5th class is antipsychotic medications, which are particularly important to limit in our seniors and in long-term care settings. When person's medication regimen changes, such as a new medication being prescribed or a current medication being discontinued, there's a greater risk for which another medication might be started, and this can cause a prescribing cascade. This can further contribute to polypharmacy, and polypharmacy is anyone taking 5 or more medications. Our aging population is more vulnerable to specific medication adverse effects than younger patients. This is due to several circumstances of the aging process, including decreased kidney and liver function, being prone to dehydration, and also being sensitive to the cognitive effects of medications. It has been reported that the risk for experiencing an adverse drug event is 88% higher among patients taking 5 or more medications. Depending on the reference cited, anywhere from 1/3 to 1/2 of patients 65 years and older are on 5 or more medications. So you can appreciate that this is a common concern. Drug-to-drug and drug-to-food reactions can also contribute to adverse drug events, and over-the-counter medications as well as herbal and alternative supplements. We can become complacent with the assumption that over-the-counter products are safe. Over-the-counters such as aspirin, ibuprofen, naproxen, cranberry, garlic, vitamin E, fish oils, and others can increase the risk of bleeding. So use caution with these agents. Transitions of care are a perilous time for adverse drug events to occur, and we will talk about this more, just as I stated before at our last Focus for Health session. So although this is what I'm going to show is an older video, it still holds true today. And I believe it shows that though we've made some progress, we have a long way to go in working on eliminating drug events. Drug safety is so important in identifying near misses and reducing medication errors. Oh, it's going to play already. Identifying and mitigating the potential risks associated with the high-risk drugs that our patients and residents are taking is imperative. We need to work on patient and resident education, family education, any communication and observation piece. It just can't be understated. Now, I'm going to stop sharing quick because I want to make sure that I have the communication on. Thumbs up if you can hear it when it starts here.
Hi, I'm Dr. Dan Budnitz, Medical Officer in CDC's Medication Safety Program. Recently, we looked at how often people go to emergency departments due to adverse drug events, or ADEs. ADEs are the unintended harm which can be caused by medications. In 2013 and 2014, about 1 out of every 250 people in the US went to an emergency department because of an adverse drug event. And over 1/4 of these patients required hospitalization for further treatment. Adults 65 and older were 3 times more likely to go to an emergency department for an ADE and 7 times more likely to be hospitalized compared to younger people. Overall, blood thinners, antibiotics, diabetes drugs, and opioid painkillers were the most common drug classes in these ADEs. But the leading drugs involved varied for patients of different ages. Among patients 50 and older, diabetes drugs and blood thinners were the leading causes of emergency visits for adverse drug events. Now, these are critical medicines for many patients, but they must be carefully managed by both patients and their doctors to minimize the risks and maximize the benefits. For patients younger than 50, antibiotics were the most common cause of emergency visits for ADEs. In fact, antibiotics caused over half of these visits among children under 6, and nearly 1/3 of these visits among those 6 to 19. Allergic reactions are the most common adverse events from antibiotics. And the best way to prevent these is to avoid prescribing antibiotics unnecessarily. This prevents harm to patients now and helps ensure availability of effective antibiotics for patients in the future. For more on this study and what you can do to help reduce emergency department visits from adverse drug events, go to cdc.gov/medication-safety and cdc.gov/getsmart. Thank you.
Currently, adverse drug events are causing around 1.3 million emergency department visits each year, and around 350,000 patients each year need to be hospitalized for further treatment after an ER visit for an adverse drug event. People typically take more medicines as they age, and the risk of adverse events increases as more people are taking more medicines. And as they stated in that 2013, 2014, we just keep seeing more and more adverse drug events related to opioids, and that is in North and South Dakota as well. So the pathway connecting a clinician's decision to prescribe a medication and a patient actually receiving the medication consists of several steps, as we have here. So ordering, the clinician must select the appropriate medication, the dose, the frequency, and duration. So what do they need to do? Avoid unnecessary medications is the first step. Use computerized physician order entry if possible, and do a good medication reconciliation. 2 is transcribing. In a paper-based system, an intermediary, a person, a clerk, a nurse, a pharmacist, or a pharmacy technician must read and interpret the prescription correctly, or use computerized physician order entry. Then there is dispensing. The pharmacist must check for drug-to-drug interactions and allergies, then release the appropriate quantity of the medication in the correct form. Pharmacists need to oversee the medication dispensing. We need to work on using tall man lettering and other strategies to minimize confusion between look-alike and sound-alike medications. Use automated dispensing cabinets for high-risk medications, as we've been talking about. And adherence is needed for the 5 rights of medication safety. Then there's the administration piece. The correct medication must be supplied to the correct patient at the correct time. In hospitals or long-term care settings, this is generally the responsibility of nurses or other trained staff. And in ambulatory care, the responsibility falls to the patients or the caregivers. So what can we do? Use barcode medication administration. Minimize interruptions. Use smart infusion pumps. Use multi-compartment medication devices. Adherence to patient education and revised medication labels to improve comprehension of administration instructions. There's a lot of other things we can do to help this. There's so many steps in preventing ADEs. The widespread use of electronic health records has helped avert and avoid many errors at the ordering and transcribing stages, but the errors still persist, and studies have found a high rate of medication administration errors in both inpatient and outpatient settings. So preventing medication errors requires specific steps to ensure safety at each stage of the pathway. So now we're going to talk a little bit about Joint Commission. The 2023 National Patient Safety Goals is medication safety. And even if you're not Joint Commission, you can still follow Joint Commission standards when it comes to patient safety goals. They do work. There are a plethora of different organizations that Joint Commission works with. There's ambulatory health, national patient safety goals. There's hospital, there's nursing home. I think the majority of people we have on here are hospitals and nursing homes. So the nursing home, new national patient safety goal related to medication safety is take extra care with patients and residents who take medicines to thin their blood. Record and pass along correct information about a patient or resident's medicines. Find out what medicines or patient the resident is taking and compare those medicines to new medicines given to the patient or resident. Give the patient or resident written information about the medicines they need to take, and tell the patient or resident it is important to bring their up-to-date list of medicines every time they visit the doctor. That's just an overview of what that is. There's home health, there's behavioral health national patient safety goal. The critical access hospital is before a procedure, label the medicines that are not labeled. For example, medicines in syringes, cups, and basins. Do this in the area where the medicines and supplies are set up. Take extra care with the patients who take medicines to thin their blood. Record and pass along correct information about a patient's medicines and find out what medicines the patient is taking. Compare those medicines to the new medicines given to the patient and give the patient written information about the medicines they need to take. And same thing, talk to the patient about the medicines and make sure they bring a list every time they visit their doctor. Medication reconciliation, there's a large number of people receiving healthcare who take multiple medications, and the complexity of managing those medications make medication reconciliation an important safety issue. A clinician should be comparing the medications a patient should be using and is actually using to the new medications that are ordered for the patient and resolve those discrepancies. The best medication reconciliation requires a complete understanding of what the patient was prescribed and what medications the patient is actually taking. It can be difficult to obtain a complete list from every patient in an encounter, and accuracy is dependent on the patient's ability and willingness to provide this information. That was all from the National Patient Safety from Joint Commission. So. We talk about tracking adverse drug events, follow your internal policy on reporting, include preventable and non-preventable events. Sometimes we think an occurrence such as constipation or a low blood sugar as expected, but there may be an opportunity to prevent a more severe episode or adverse drug event. Encourage sharing of near misses, even if by having a query at shift changes, at huddles or staff meetings. Have a safe space for sharing so that those scenarios are at top of mind. Do audits and review your own data for trends and opportunities. Review event report details and look for common threads. You could run a report on an abnormal lab results out of your EHR, such as low blood glucose levels or out of range INRs. You can also do the same for antidotes administered, such as vitamin K, glucose, or naloxone administered. Since you've joined Adverse Drug Events Series, we believe you might have an interest in developing a quality improvement project related to adverse drug events, or maybe you have one, or at least you're thinking about beginning a quality improvement project for adverse drug events. So we do have a Great Plains Quality Innovation Network Quality Improvement Project Guide and Tools. It can look overwhelming when you open it up, but we have a lot of different tools you can use. You don't have to use them all. You pick and choose. You do a root cause analysis. You define your problem after you've built your team and you've analyzed your data and you've chosen one area you want to work on. And if you want help, we are always here to help you. We're here to support you, meet where you are in your quality improvement journey. So just let us know what you need to do. We want to help you be successful. With that, I'm going to turn this over to Carrie, who's going to have our office hours portion of our call. So I'm going to let Carrie take it away.
Thank you, Tammy. So this is a time for you to come off of mute and ask questions, or feel free to type them into chat and we will take those. And then while we're waiting a few minutes here, let's just launch a couple of poll questions. So Tammy, if you could launch the first one.
Yeah. Oh, and they're actually in here. Last time, you know, my drafts were gone. So I'm so happy they're here. All right. The first one is, and I'm going to launch it now. Is your organization currently working on a process improvement project related to decreasing adverse drug events? So you should see it in the middle of your screen. And if you don't, it might be in chat. You might have to open chat up. So, should be seeing it now. And all time, we'll give about 20 seconds for people.
So it looks like we have 2 yeses and 1 no.
Okay.
So that's good.
We'll leave it open for about 10 more seconds.
So yeah, it looks like the majority of those answering are working on a process improvement project related to adverse drug events.
All right. We have another poll. This next one is, what class of medication do you see most adverse drug or ADEs in your facility? And it is, if you see a couple, you can click more than one answer. Or we don't have an ADE problem. We'll wait maybe 15 more seconds. We have 2 responses, if you can, or 3 responses, 2 responses.
Yep, I see we've got 1 for anticoagulants, 1 for anti-diabetics, and 1 for antibiotics. So,
Okay.
yeah, I think the national trend is to see the majority of events coming from anticoagulants, but certainly those are the top in the top 4 classes of agents that contribute to our problematic ADEs. So,
For sure, for sure.
yeah.
I'll just look here to see if we have any questions.
Well, while you're looking, I just wanted to mention a few more things about the Joint Commission 2023 National Patient Safety Goals. As Tammy mentioned, you can access those strategies and tips related to whatever facility type you're in. So I think there's at least 10 different chapters that are focused on facility specific recommendations. And so you're able to go in and look at that chapter. It's outlined by each goal. And then there's also a shortened, just like a 1-pager that really summarizes nicely the goals that have been identified as kind of those top offending areas to make improvements. And so it really doesn't matter what facility type you choose. Really, the overarching themes to support the safe use of medications are the same. So labeling medications is really important, and it is a area where a lot of medication errors occur. I think, we can be in a hurry when we're transferring medications to syringes or cups and basins, thinking that we're going to administer those right away, and then, a distraction occurs, and then mistakes can happen. So it's always really important to label those medications once they're transferred out of their original containers. Secondly, those anticoagulant medications, since we know they're the #1 cause of ADEs on a national level, really important to ensure that those narrow therapeutic index medications are administered safely and monitored. We know that there's so many things that can interfere with the blood levels of those medications. It can be other medications, it can be over-the-counter products, herbal supplements, even just acute illnesses. A lot of our patients, as they're transitioning from different levels of acuity, can be sicker, and that can affect the overall absorption and metabolism of medications and make those drug levels fluctuate. So it's really important to be monitoring those medications to the best of our ability, and monitoring for any side effects such as unusual bleeding, nosebleeds, blood in the stool, and things like that. And then lastly, just the medication reconciliation process is so important through all levels and transitions of care. You think about the average patient, how many times we're transitioning from, going to a clinic or going to a specialty provider, or, going into the hospital or to a nursing home, assisted living. At every one of those points, there's such large potential for medication errors to occur for various reasons, but communication is a big one. And so we always want to make sure that we're communicating with our patients, residents, their family members, the provider, nursing staff that are taking the baton from that primary facility. And so we will be focusing on medication reconciliation in our 4th week of this series to really dive into that topic further. So do we have any more questions that anybody would like to come off of mute and ask, or anything in the chat, Tammy?
I don't see anything. I think we can call it for today. So thanks everybody for joining, and please scan the QR code and complete the evaluation.